Dr. Mark Piper, thank you so much for being here.
Thank you, Greg. I'm not sure what you came to hear, but we're not going to talk about what's in the program. The talk is about classification, and there are different ways of classifying patients. So what I'm going to do today is take you through a classification of pain, and it's a working classification that I use at the Piper Clinic. And we're going to take one layer in particular and kind of cover concepts in some things that are happening, I think, in our practices that we may be missing. And I want to start with a list of symptoms. And so imagine a patient comes into your practice and she has had a procedure to close the diastema. And that diastema is between teeth numbers 7 and 8. And immediately she gets symptomatic in tooth number 7. So she has multiple adjustments the next few weeks. And with each additional adjustment, the pain gets worse until finally she ends up with a root canal. And you say, how do you get a root canal from having a restoration to close the diastema? But the story doesn't end there because after the root canal, the patient then develops TMJ pain on one side, and so she continues seeking treatment from doctors, splints, and various types of therapy, and everything she does, she gets worse. So then she does an occlusal adjustment, and she develops left TMJ pain, starting with a diastema, okay? Incisors are then premature, her jaw is shifting, and she can't come off of the incisor dentition. She gets chin pain, headaches, ear pain, gingival pain, stiff muscles, burning sensations in the lower jaw, visual scotomata, and then cold. Cold makes her hurt more when it hits her skin. Cold fluids on her teeth can't be tolerated at all. And she gets bizarre things: increased axillary sweating, cheek swelling, ear congestion, positional vertigo, swallowing difficulty, and cervical pain, all from closing a diastema. That's what we're going to be talking about today, is this type of patient. And it's a condition called complex regional pain syndrome type 1, also known as reflex sympathetic dystrophy. And I will do a brief diversion to the overall classification, but I really want to get to the pain slides so that we can talk about this condition in detail. And I'll go through the presentation in general in the body, and then we'll talk about how this impacts the oral environment and the face. So these patients that we're going to talk about come from baseline patients that I see in my practice. And a lot of what I treat is failed therapy. And that's actually kind of a good thing, because the learning curve on failed cases is dramatic compared to what we learn if we have nothing but successes. And because I can draw these patients in, it gives me a special opportunity to do some things to assess them and try to find out what all is going on with them. So it's really 3 different areas, but they blend. These are all the same patient mix. Your TMJ problem, your facial skeletal pain, your skeletal defects, they all go together in these patients, and that's why we classify. And the classification, which I won't go through today, this part of it, is the actual classification of the joint foundation. And suffice it to say that we have medial pole and lateral pole problems. The lateral pole problems are actually quite a bit simpler, and these are stages 1 through 3. And again, I'm not going to go into great detail, except to say that the medial pole is intact in stages 1 through 3, but you can still get CRPS type 1 in this population. And it's much like the patient that I just presented. It happens after a very simple dental procedure, a slip and fall, or something that ends up with pain patterning that's way, way out of proportion to the inciting event. And then in the classification, we have stages 4 and 5. And these are stages where the medial part of the disc is out of place, and what follows is occlusal drifting. And the occlusal drifting basically results in loss of dimension at the level of the temporomandibular joint. The condyle's closer to the skull base fossa, and this creates a shifting in the bite. And so from the first part of the classification, there's a second part that's occlusion. And basically, in a very simple way, this is angles classification mixed in with joint condition. And you can see in the first column I have normal joints. And then there are two types of abnormal joints. There are adapted abnormal joints and there are non-adapted abnormal joints. And in each of those columns you can have angle class 1, 2, or 3. So in this talk, in part, we're going to be talking about column number 3, the non-adapted joint, because the presentation on CRPS is also a presentation on muscle dystonia. It's a presentation on osteopenic and osteoporotic bone. It's a presentation on degenerative tissues. And so this part of the triad would obviously fit the patient pool. But what I really want to get to is the pain classification. And again, this is one I've worked with for a number of years at the Piper Clinic. And to make it simple, there are 3 pies, and each pie has 3 pieces. And the first pie is pain associated with TMJ injury, and those injuries can be variable. They can be stretch injuries from an anesthetic procedure or chin traumas. I'll show you a brief video here in a minute on how these traumas occur. And then we have in the literature hormonal influences, connective tissue disorders leading to internal derangements, occlusal microtrauma, and a big group of unknowns. So when you take the piece called muscle, classical presentation is that we have a malocclusion creating reflex spasm in the muscles of mastication. And so the question is, well, how do you get the occlusal prematurity to start with? Is it acquired? Is it natural? If it's natural, why does it suddenly trigger muscle pain? And oftentimes with joint injury, we end up with prematurities on the back teeth. And these prematurities do start a process of bruxism and clenching. And so we parafunction. And parafunction is of different types. We also have sympathetic induced facial dystonia. And again, that's going to be a big part of this talk. So when you take that one little piece, muscle, there can be a number of different explanations as to why muscles may be hurting. And in the lecture, I'll try to teach you what the sympathetic nervous system does to create muscle dystonia. The second piece here is intra-articular structural, and these are things you're all familiar with. Concepts of disc herniation, concepts of inflammation in the joint, adhesions, and this last term, hypoxia. Hypoxia creates pain, and we'll talk about that a little bit too as we talk about CRPS type 1. And then bone. Bone is the third piece in this particular pie, and bones can be contused with trauma. You can have fractures, obviously, but a lot of pain in bone is marrow congestion or edema. Just like we get edema in a pulp, we get edema in a bone marrow. And a bone marrow, a condylar head, is a closed space. And a closed space is subject to what's called a compartment syndrome. A compartment syndrome is nothing more than swelling inside a closed space, and the swelling chokes off blood flow. So the analogy in the pulp follows, the analogy in the condyle follows. But in sympathetic pain patients, we also get atrophy of tissues, and one of the primary observations in this population is osteopenia of bone. So that's pie number 1. Pie number 2, when we get a trauma, we oftentimes injure other things. And so a whiplash may injure the TMJ and the cervical spine simultaneously. So as you look at this pie, you can have post-traumatic tooth pain, and that could be from direct damage to the teeth. You could also have pain in the teeth because the joint shifted dimension. You're now premature on the teeth, and you're hyperfunctioning in those teeth. But again, in this lecture, we're going to talk a little bit about pulpitis that's sympathetic induced, just like the example I started the lecture on. How does closure of a diastema lead to a root canal? How does a root canal lead to TMD and cervical problems and muscle dystonia? there is an explanation. So the odontogenic layer could include periodontal injury, and then there's a phenomenon of neural convergence of different types of layers coming together. Neuralgia, the classic neuralgia, is in the trigeminal system, and you could get a temporary neuritis following a trauma, or you could get a true neuralgia, which is basically electrical shock in a branch of one of the branches of the trigeminal nerve. It's brief, it's electrical, it's stimulated by light touch. Very, very different from the pain we're going to talk about today. And then cervical, this is a big deal. This is a much bigger deal in oral facial pain than what a lot of people realize. And I'll tie in the cervical connection. But I will tell you that in imaging both TM joints and cervical spines, it is rare to find a damaged TMJ that does not have damage to the upper C-spine. And that upper C-spine damage creates a lot of pain patterning and secondary sympathetic induced pain as well. And then this is pie number 3. This is the complicated stuff. And the way I like to think about this pie is pain that is stimulated by other pain. And so if you have sleep disturbance, for example, you're going to eventually get different kinds of pain patterning in different layers. And these are 3 pieces that I always try to screen patients for. One is migraine, and migraine is a vasoreactive phenomenon, basically vasoconstriction, usually, and then vasodilatation. But there are variants. You may get one and not the other. When you get the vasodilatation in the cranium, you now have a compartment syndrome. You're going to get a headache. And we'll talk a little bit about how this may come out of the sympathetic nervous system as I go through some of the anatomy. But migraine can be a secondary pain. If you have chronic tooth pain, chronic TMJ pain, chronic sinusitis, oftentimes that'll trigger a patterning of vasoreactivity and you'll get migraine headaches. Fibromyalgia is a syndrome, and we've known about it for a long time, but we still don't understand a whole lot about it. There used to be a way of assessing it by looking at 18 points on the body. You would put pressure on these so-called trigger points, and if they had 11 of them positive, then you would say, okay, you've got fibromyalgia syndrome. We don't have any other explanation for your pain. This has been greatly simplified now, and I kind of like this because the American Academy of Rheumatology has redefined this just simply from a questionnaire. And they have a scale now by asking questions like this about symptoms and duration and dysfunction created by fibromyalgia. They can scale these patients now. And so diagnosing fibromyalgia is a much, much simpler thing to do than we did in the past. Crossover with this is CRPS. And this stands for Complex Regional Pain Syndrome. This used to be known as reflex sympathetic dystrophy. And this is the incapacitating pain. This is the unusual response that you get to a minimal trauma or to a minimal stimulant. And unfortunately, the science in the head and neck area is very poor. It's really not very good in the extremities either, but at least it's been seen and acknowledged and picked up by MDs in the extremities for a very, very long time. So there are different types of this. And to give you a brief overview, type 1 is a component of coexisting disorders typically. Type 1 is basically distribution of pain that's in a broad area or region in the body following some type of an insult, but there's not a direct injury that we can tell to nerves. That's actually CRPS type 2, which used to be known as causalgia. So let's say you have a crush injury to a nerve, and you look at the nerve, you can see the crush injury, or it's been sectioned or something like that. You can get this so-called causalgia type pain, which is type 2. And then there's the type that's not otherwise classified. That would be CRPS NOC. And this was kind of a category of patients who were caught in the middle of some diagnostic criteria between the 90s and the 2000s, where they didn't fit the secondary criteria, but they were thought to have had CRPS, so they called them not otherwise classified. and you may follow up or see that in the literature. So the whole focal point here is to teach physicians and dentists how to identify patients with facial RSD and CRPS, and I'll try to tie it into things that would be practical as a practicing dentist. Okay, so let's take a look at what this particular condition is.
She skyrocketed to stardom. But Paula Abdul claims for each success, she's endured a devastating blow. Despite her fast rise to fame, luck wasn't always on her side. Paula says she suffered a debilitating injury from a cheerleading accident at 17, but decided against surgery, choosing to live with her damaged body. In 1991, she rose to pop star status with platinum hits, but claims she suffered a broken leg in a dance rehearsal. Only 1 year later, she says she endured excruciating neck injuries during a car crash. Then, in 1993, Paula says she was left partially paralyzed after a plane crash, requiring 15 spinal surgeries. Paula reveals the cumulative effect of these injuries began a battle with chronic pain for more than a decade. But Paula put on a brave face for her millions of fans, who never detected the personal hell she was living in silence. Finally, Paula revealed she was given a diagnosis.
I thought that I was doing the right thing by being brave and not telling people that I was suffering from a debilitating nerve disease, and it's called RSD. And by not telling people and thinking that I could make it light and everything like that, you see, it was not the right thing to do. Actually, being really brave would have been to be able to discuss it.
Well, describe the pain to me. I just want to understand what it's like to live through that.
It would start always at my neck, and it would be on the right side primarily, and it would shoot from the base of my neck to my right shoulder, down my right arm. My fingers would lock up, fire, stabbing pain, burning, needles and pins, and a constant, like someone was just poking me all the time, not with a soft object, but a hard one. And it's crazy, but you learn that you learn how to adapt to it, but you learn that's not normal.
So, this was my first CRPS patient back in 1983. And she came in with dystonia, along with a lot of pain. The dystonia kept her jaw deviated to the left. And we were attempting occlusal adjustments. I was going through everything I could try to discover about central nervous system dystonias. And basically, she died before any diagnosis was made. But this is the kind of patient who starts you on a pathway of looking and trying to discover more about what's going on. Here's another one. This is an interesting story. A patient lived in Miami, and there was a traveling dentist who literally came in with a suitcase. Her husband could have bought Coral Gables, but she didn't want to leave home. And so the traveling dentist came in to do restorative dental work, and she subsequently developed CRPS type 1 in the face. And you can see things like dilation of the pupils. The altered blood flow in the face creates skin discoloration, and that also creates edema. I'll show you this in a minute. There's muscle dystonia, again, primarily in the muscles of mastication, but you can also see it in the facial musculature. And so they have a stiff-looking face, almost a marionette-like face, very poorly animated when they're talking. And then they have eyelid ptosis. You can see the ptosis of the eyelid here on the right side. And then subcutaneous edema is a hallmark of this. In the face, you'll see it under the cheeks. Also the eyelids and the pinna of the ear. There's no area for fluid to spread out along the ear, and so that's a good place to look for shiny skin, and that's edema in the ear. So if you're following one of these patients, that's one of the things you can actually track. Physician's wife from Michigan had TMJ surgery that failed. She had implants placed that became infected, and the surgeon washed them out, put new ones in, and guess what? The infection wasn't cleared up. And so she ended up with no joint. and you can see she's got the classic eyelid ptosis, subcutaneous atrophy. The cyanotic bruising around her eyes is basically decreased blood flow. It's sludging in the venules around the face, and so that's the discoloration. And then the dystonia of the muscle is rather extreme. This presents as spasm. You ask them to open, they have a very difficult time initiating opening of the mouth. They also have a difficult time trying to close. And so it's almost like they have to think about the movement of the jaw before they actually do it. And because of the dystonia, they have variable posture in their mandible. If you're trying to establish a bite registration or eccentric relation, it's really hard to do because if you wait a minute, the dystonia is going to happen somewhere else. And then they have perseveration of the jaw, and that's kind of a ratchety movement as they're going into excursive movement. This young patient had a car semi-accident. She was in the car, and she developed total body CRPS type 1. Basically ended up wheelchair bound. Had a lot of this going on in her face as well. And so it looks like Rose. You know, they stopped taking care of their teeth. Hygiene is a problem because it hurts to brush their teeth. It hurts to touch their gums. Sometimes they can't even open up enough to get a toothbrush on the inside, and so it's a real problem. I'll let Ben tell his story a little bit as well.
This is Ben. Ben met me about 6 months ago or so. First came year and a half ago. The show's not long. And when you came in at that time, you had several different things going on. Can you just kind of take me back to that? Tell me what you were noticing when you came in here, kind of a quick version of what your history was before that.
Well, I was in a motor vehicle accident about 10 years ago, and I developed extreme jaw pain after the accident, which continued to get worse for about 4 or 5 years. Then I had surgery that just made things worse.
And with that surgery, they put in a liner on the right side, and they did a disc repair on the left side, correct?
So a lot of these patients come to me because they have had TMJ procedures. They've had restorative dentistry, and his started with a trauma, but the point is that if this is unrecognized, everything that we do, they just simply get worse. And so this will start out this way. It's going to have a history of trauma or surgery to the affected area, and it can be minor surgery. Think diastema closure. Pain is disproportionate to what we did. So we have a certain concept. I mean, you take out wisdom teeth, you have a certain concept as to how long they should have pain. These patients have pain forever, or they have pain for a far, far more extended time than you would expect. And so they're exceeding the duration of symptoms that you would usually expect. And this is a non-dermatomal distribution, which basically means it'll cross multiple divisions of the trigeminal nerve when it's in the face. And when it's in the extremity, it's going to cross multiple spinal nerve levels as well, and non-dermatomal distribution. And there's something going on in each of these areas at some point. There's dysfunction of the sympathetic nervous system, and that's where we see the sweating and the blood flow to the skin being altered. They get edema, like I've demonstrated, and the dystonia, and then they get changes in tissue, and this is atrophy and dystrophy. And so it's a pain condition, and it gets worked up primarily as a pain condition, but it's got these 3 other things going on as well. And in particular, the muscle dystonia is a big deal because it can actually deform joints. You'll see pictures, if you research this, of people with deformed extremities because of the decreased blood flow. And they don't have to have all of these things all at once. I'll go through how we actually diagnose them in a minute. And they can have remissions and relapses, okay? So emotional stress is a big deal. Weather changes are a big deal because they get worse when they're exposed to this. So you might say, well, how do you actually get trauma in the face? And what kinds of things are we talking about? Well, we're talking about everyday things.
I'm looking. I'm gonna hurry up. Yeah.
Oh, Jesus!
Is there anyone with step door? Please.
Might not want to watch.
Is Tony died?
Yeah. Oh my God.
So the interesting thing is not only do you develop pain, but this is also how you lose canine guidance. Okay, let's look back at the disorder and kind of tell the story of this. This was originally described in the 16th century in King Charles IX, who was undergoing bloodletting and developed symptoms consistent with complex regional pain syndrome. And then in 1766, there's description of this syndrome after a joint injury by Hunter. But it was really 1864 in the Civil War when the father of American neurology, Silas Weir Mitchell, described what Civil War wounded veterans were going through in terms of pain patterning. And you can see his description, which eloquently talks about this burning pain in the extremity and the distress that it causes in patients. And simple things like vibration and so forth would tend to make this pain worse. And they started in this situation with war trauma, but he began drawing our attention to pain that extended beyond the area of injury and kind of drew our attention to the enormous distress that these patients would suffer once they got the condition. So I've included some literature, and I can get copies of the presentation to everybody who is interested, but there's a lot of literature. This is only part of what's in the medical literature, kind of from a historical perspective. The term causalgia was actually dated back to 1868. by Mitchell. And then Sudak started talking about inflammation and vascular changes and sympathetic dystrophy, and that was in the 1900s, earlier 1900s. And then they started talking about cycling of this pain. And Livingston actually found, and this is very interesting, that people who are inactive are a little more likely to develop this condition. So that's actually looked at as an etiology. You know, if they're inactive and they're not using the body part, the spread of CRPS type 1 is more likely to occur. The term reflex sympathetic dystrophy, which is what I learned in medical school, was coined in 1947. Okay, and then that was subsequently changed in the 1990s, as I'll show you. And then 1964 was the first report of associated dystonia. Remember, it's not just pain, it's muscle dystonia as well. And that was Weirs-Hosels who described that. So here's what the International Association for the Study of Pain has done in terms of diagnosing this condition. And their history goes back to 1993 when they held their first consensus workshop, and they started getting together and gathering up the different diagnostic features. And then you can see there have been several revisions. The 2003 meeting was classic meeting at which the so-called Budapest guidelines were developed. Those are the guidelines that more or less apply to modern diagnosis. And then in 2013, there's a well-written article here to review exactly what that is, if it's something you want to follow up and do. And so in 1994, they changed the term RSD to CRPS1, and then causalgia, which is actual nerve damage, they termed CRPS type 2. And they felt that these conditions were started by crush or soft tissue injury or immobilization. But CRPS2, there's actually direct nerve damage that could be seen. And so the hallmark is pain disproportionate to the injury. And they're extremely sensitive to touch. The diagnostic category started picking these patients up reasonably well. And then there was a revision in 1999 that basically started identifying the subcategories of this. But it was 2003 where from the Budapest guidelines they came along and said, okay, you've got 4 symptom categories, and if you have, if you basically have 3 of 4 symptoms in your history, that goes along with CRPS, and you have to have 2 signs at the time of the examination. So that's pretty much what has been adopted today in terms of diagnosis. So let's go through these categories. Sensory. You have to have 1 symptom in each of the 4 categories. Sensory would be hyperesthesia or allodynia. Vasomotor is temperature and skin color change. Pseudomotor is swelling and sweating, and pilomotor goosebump effects. And then you've got motor problems and trophic changes. So altered mandibular movement, history of that, patient noting atrophy in the subcutaneous tissues, gingiva, or something like that. And then they've got to have a sign in 2 categories at the time of examination. And again, it's the same 4 things. Key thing is that there is no other diagnosis to pin the patient's complaints on. And so if you rule out all other diagnoses, that's kind of a starting point. And then by process of elimination, almost you end up with fulfilling these diagnostic criteria and assigning the conditions named to the patient. So here's the dental perspective. And I want to start out with a few statements about our pain colleagues in medicine. Many of them are very poorly informed about facial CRPS. They'll deny the existence of facial CRPS, even going so far as to pompously declare that the condition can't exist in the head and neck area. These are my favorite people. This is a tremendous disservice to the patients, because if you're not treating this condition, then it's going to spread. Okay, it's going to spread. It can spread from the face into the rest of the body. It can become more chronic and centrally maintained pain. And these doctors who are skeptical about Cribb's diagnosis in the face very oftentimes drive the patients towards very expensive, unnecessary treatment. Cervical facet blocks, implant pain pumps, and so on and so forth. And to put it in a nutshell, these doctors are full of it, okay? They really don't know what they're talking about. And so this is the first time I've made that revelation from the podium. But let's just look at the facial CRPS literature for a minute. And here's the latest case that I found. A 13-year-old girl who had crypts in the face, and she fulfilled the Budapest diagnostic criteria for facial crypts. And she, I think, was struck with a snowball, ended up losing her eyebrow hair. Loss of hair is part of the atrophy process. Eyebrow is a little bit unusual. So they said, okay, she fulfilled diagnostic criteria for CRPS in the face, and she actually recovered from this according to their report. And then historically, you can go all the way back to 1954 in the O journal where this condition was reported. In the medical literature itself, there are a number of reports. A couple big names are Waldman and Hushman. I'll go through some of their insights about facial CRPS here in a minute. And so you can see the literature. There's lots of literature. And I guess these doctors who say it doesn't occur in the face must not read the literature because it certainly is there. And then down here you can see, again, Waldman is a name that pops up a lot. And I'll show you a book that I really think you should buy that goes through a lot of different things. Okay? The last paper here is an article that came out of Tufts University back in 2012. And so basically what they did is they looked at the dental literature at reported cases. And they had some conclusions. One was no standardized criteria for the diagnosis of CRPS are in common use. Well, that's not true. It may not have been in common use when these papers were reviewed, but there is standard criteria. And they said it's evident that pain is the main feature of the disease in the face. Well, that's wrong too, because dystonia was never measured. And so these were reported purely as pain conditions. So when you read this paper, they're missing 3 of the 4 diagnostic criteria because the case reports just simply didn't look at those types of things. And these are the cases here. You can see the different etiologies: penetrating shell fragment in the cheek, mortar wound, extraction second molar on the bottom, carcinoma, cancer is a big one, preceding crypts, trauma to the left side of the face by a sail boom, left maxillary molar extraction, frontal sinus osteoma removal, car accident with fractures, left maxillary molar extraction, external to internal carotid transposition, I believe that was, and then car accident to the head and neck. Okay, so it's in the literature, and it's not a great amount of literature, but these cases are there, and patients that we see do fulfill the Budapest diagnostic criteria. This book is out of print, but it's actually a classic, and it was written by Hushman on chronic pain and RSD. And I'm going to quote Hushman quite a bit, but to take little pearls out of his textbook, he noted in chapter 5, if you look at the bottom line, the sympathetic originated spasm involving facial muscles results in TMJ disease. So he felt that the spasm in the face would eventually overload the TMJ and cause a TMJ disorder. He also, very interestingly, noted that trauma to the cervical spine results in pain in the distribution of the trigeminal nerve. And we know now from more recent studies, you can actually extrapolate that to the thoracic spine. And when I go through the anatomy of this, you'll understand it a little bit better. The role of cervical spine pathology in RSD has been recognized by few clinicians. This book was written in 1993, and 25 years later, you can say the same thing. Very few clinicians recognize this disease, and Hushman himself said RSD may complicate TMJ disease and vice versa. This is a link that you might want to get. It's rsdrx.com. Hushman is now retired, He's kept his website up. He's got what are called pearls. So he called them RSD pearls, and basically what he did, the patient would write to him about RSD, and he would write back and kind of explain their symptoms. I knew Hushman personally. I worked with him for 20 years. He's the one who taught me about facial complex regional pain syndrome. He and I probably saw scores, if not hundreds, of patients that we shared. In fact, it was an interesting story. When I had my first suspected RSD patient, I called him because he's about 120 miles from me in Florida. And I said, I have a patient that I think has facial CRPS. Would you mind seeing her? And he humored me. He said, I'll be happy to see her. He said, but it doesn't happen in the face. And I said, okay, you'll see her. I'd appreciate it. And he called me back and said, well, yeah, you're kind of a hotshot. You did pick this up. He said, but you'll never see another one. And I said, would you like a few more? And so he and I developed a great working relationship. Wonderful, wonderful man. I've lectured on CRPS at some of his conferences, the medical conferences he ran. And he really took a keen interest in his patients. And he had the kind of practice that treated total body RSD, where the sympathetic nervous system throughout the entire complex was just horribly injured. And again, RSD and TMJ pain, he says patient develops muscle tension headaches and spread of the muscle spasm of the facial muscles with resultant stress on the TMJ. Now I think what he was missing was that the TMJ oftentimes was already injured and set the patient up to be at higher risk for CRPS. But again, at least he made the observation. This is an MD neurologist making an observation in the face that most dentists, in a condition most dentists have never heard of. And he really picked on root canals and so forth. He felt that root canals actually were being done for the wrong reason. And I have to agree with him. So when you develop edema from CRPS, basically the edema is throughout the tissues. It'll be submucosal, subcutaneous, it will be intrapulpal, and it's the intrapulpal edema that gives us tooth pain. And as dentists, we think every time we get a tooth pain, we've got to think in terms of a root canal. The root canal is a surgical procedure done for the wrong reason, and instead of treating the edema, if you pull the nerve out, you now have localized nerve injury to the sympathetics, and they're spread. The root canal fails, they've got to repeat it, and eventually they end up getting the tooth extracted, and in a common presentation, this will then shift to the next tooth or teeth in the quadrant. And again, unrecognized, this will simply tend to spread. Hushman recognized this. He saw these patients who came to him after root canal therapy developing facial and cervical CRPS type 1. And he wrote about it. You know, this was published in 1993. He was observing it before that particular point in time. And so he's pretty adamant, or was very adamant, about not having root canals. Now, if you think about the definition of the disease, if you have an explanation for the pain, if there's caries, if there is a pulpal infection, there's no argument. He didn't say don't do root canals if there's another disease entity to explain it. He said don't do root canals when teeth hurt and there's nothing there to explain why the tooth is in pain. You know, that's part of what the CRPS is. And here's a letter he wrote to a patient like you with craniofacial RSD invariably suffers from headache, dizziness, neck pain, and tinnitus. Such patients benefit tremendously from paravertebral nerve blocks in the cervical spine and occipital regions, okay? And then he talks about burning pain in the mouth, again, related to CRPS type 1, and this is in his puzzles in the online content. Now, Waldman wrote 3 editions of this book. You may want to get it. This is called Atlas of Common Pain Syndromes. It has a sister volume called Atlas of Uncommon Pain Syndromes. Well, guess where he put facial CRPS or RSD? Atlas of Common Pain Syndromes. Okay? And so he describes RSD in the face and neck and parallels to the same things you see in the upper and lower extremities. Okay? So this is an MD, pain specialist, anesthesiologist, writing a book on common pain syndromes and facial CRPS. RSD is in it. Do you think those pain experts who say it doesn't exist in the face know what they're talking about? They don't. Okay? It's throughout the literature. He found a lot of it with cancer patients, just like you see in the dental literature as well. And again, all the hallmark signs and symptoms that we talk about with burning facial pain, the allodynia in the skin, and so forth. Okay, so let's define some terms. Hyperalgesia is an increased sensitivity to pain or pain caused by damage to nociceptors or peripheral nerves. Okay, so there could be focal, discrete areas or more generalized diffuse areas where you've got increased pain as a baseline. Hyperesthesia is any condition that increases sensitivity to stimuli. And so you could get some people get sensitive to sounds, and that's actually an auditory hyperesthesia. But what most people think about in terms of hyperesthesia is tactile hyperesthesia, whereas you're touching the patient, they're saying, oh, that hurts. You know, what hurts really hurts them a lot, so an injection would really bother them. And then allodynia is really when the pain probably becomes more centralized. This is now a burning baseline of pain. You'll see images that people draw where they draw their faces on fire when they have this type of thing. So allodynia is pain to things that normally don't cause pain. So think about teeth. You know, if you put ice on normal teeth, they wouldn't hurt. But throughout the literature and with Hushman, there are descriptions of ice hurting teeth. That's an allodynia, okay? That's nothing but an allodynia. So part of the disconnect between dentistry and medicine is we don't use similar terminology. If dentists would call it what it is in the medical arena and say, okay, they have a cold allodynia on the lower left quadrant, okay? Boom, that qualifies for pain patterning. And then the question is, what's turning on the sympathetics and why is this happening? So anyway, this again is the review from 2013, the paper you're going to want to get if you want to go through the diagnostic criteria and have them in your office, or you can try to do what I've done here with the dental patients. And so pain processing. Hyperalgesia would be symptoms of non-dermatomal facial or cervical burning or stabbing pain, and they can also have unexplained tooth or mucosal pain. And you only need one in this whole category of these three types of pain, only one. Hyperesthesia, increased response to touch or injections. They have photophobia and hyperacusis. Allodynia, they report pain from light touch of others, not from themselves, but from others. Skin and tooth sensitivity to cold is reported. And then they have painful joint movement. You know, normally it doesn't hurt to move the joint, but these people hurt to move their mandible. They hurt to move their cervical spine, their shoulders, their fingers, and so forth. Vasomotor symptoms, okay? Temperature asymmetry, and that could be throughout the upper quadrant. The face is actually linked to the upper quadrant of the body. So you might see temperature asymmetry between the left arm and the right arm. They may show evidence of skin color changes like I showed in some of the example patients earlier. And then pseudomotor, and this is spelled correctly, it is S-U-D-O motor. This is where they develop the edema, and the edema again can be in the facial region, it can be intraorally and in particularly in the pulp. They can have nasal congestion and sinus congestion because the edema hits everything in the distribution of the pain. And then they have sweating asymmetry, as my theoretical patient example at the beginning of the lecture develops sweating in her axilla. And oftentimes what they report is they have fluid that comes out of their ears. And you look in the ears, you see nothing. That's nothing more than the sweating or fluid phenomenon in the ear canal coming out on the pillow at night or whatever. And then their motor symptoms, they have TMJ trismus, cervical stiffness, and stiffness in the joints in the upper quadrant of the body. They have difficulty initiating movement. They have mandibular dystonia. Sometimes they have difficulty swallowing. They've got deviation of the mandible often, perseveration of jaw movement, which is ratcheting movement going side to side. And then they have the atrophic changes, and the atrophic changes are subcutaneous, submucosal, periodontal. You'll lose hair, and so on and so forth. Pathognomonic, though, of the condition, interestingly, is that their nails grow fast initially in the disease. So their nails grow quicker than normal. And that's one of the symptoms that we oftentimes will ask the patients. Then they have to have signs. Okay, think about this. TMJ patient comes in, and they've got hyperalgesia, baseline of pain that's often burning. They may have unusual pain in the teeth, mouth, gingiva, so forth. They've got hyperesthesia, so if you go to inject them, they think you're a terrible doctor because you hurt them. And they're sensitive to things that would normally cause pain, but they've got an increased response to that type of thing. And then they have the allodynia, which again would be light touch causes pain, cold exposure, air conditioning hitting burnt cold skin. I mean, hitting the skin will turn this on, so they wear hoodies and things like that to stay covered up. And then ice on the teeth, deep somatic pressure, tooth contact, movement of the joints. Those are all signs of allodynia. Very, very common to see this diagnostic category present in patients who come in with facial pain. And then they have temperature asymmetry. If you feel with the pads on the back of your fingers, you can tell asymmetry in the temperature in their face, their arms, or their fingers. In particular, the fingers oftentimes will be very, very cold on the side that's involved. And then the skin color changes are what I call patriotic. That would refer to America, red, white, and blue. So they have red, white, and blue changes in the discoloration of their skin. And then the pseudomotor signs are swelling and sweating. And again, we've covered that quite a bit. You're going to look in the ear for this. You're going to be looking for fluid in the ear canals and so forth. And then the motor part of it is actually watching them move and realize you ask them to open. And they think about it, pause, and then they open. Or when you're trying to take a bike registration, you're trying to close them down. They won't let you close them, okay? And that's part of the muscle dystonia that they have. It's painful for them to do it, but also it's part of the dystonic muscle that's holding them up. So there are a lot of changes that we can tend to hear about and see in the skin.
And do you get splotchy blue areas anywhere that you've noticed?
Yes.
Ears or neck, or what do you notice?
I would say I probably don't notice as much on my neck, but I do get kind of splotchy blue on my hands, and especially at work. I sit at a desk all day, and the temperature is usually about 73 degrees, and even in the summertime, I normally have to wear something over this sweater when I'm at work.
So they have skin problems. They have problems with processing pain.
Any change in the weather caused the pain in all my joints to worsen. Wind sometimes is very painful, just to my skin. Sometimes I couldn't even get up in the morning because I just hurt too much. Sometimes just pressure on any part of my body would cause burning sensations.
What about if cold wind hit your face, what would happen?
It would hurt and it burned like fire sometimes. Sometimes it would feel like needles in my face.
And did it stay in the face, or did it spread out?
It spread. It sometimes stayed in the face and head, sometimes spread down my neck into my arms, and sometimes into my two little fingers.
And also they have dystonia.
No, I told you, that was what I noticed first was deviation.
And that was what year?
03.
03.
So everything started in 03, and I went to the dentist first because it seemed like a dental problem. So we tried some adjustments. He made this night, but he finally, by February to September, tried different things, and I was getting worse and worse and worse. So finally, the girls in his office, will you please send her somewhere else? This ain't working. I went to an oral surgeon. I had never been there. I was sitting there. The gal comes in to work with him, took my plate, part of my guard, started just put it in your mouth, take a bite. She's grinding it. I went, whoa. I go, shouldn't that have been done when I got it? And she goes, well, yeah, I don't know why you didn't. I go, well, because I didn't get it from you. And she's like, oh. So they made some severe adjustments to this thing that locked it to the left.
So, special features, the hyperesthesia or allodynia can be teeth or TMJ, it's burning quality. They get all of the diagnostic categories that we've gone through. And here's a photo collage of some of the skin changes that you can see in the more chronic forms of this in the face, and a photo collage of skin changes in the extremity. These are actually deformed joints. And so this inward distortion of the ankle is from chronic hypoxia in the leg from CRPS in the lower extremity. Okay, so this is a regulatory system. And we're basically regulating our blood pressure, pulse, respiration, everybody knows that. But we're also up and down regulating the immune system and controlling glandular function. And so when you think about the parasympathetics and the sympathetics, you can think of the parasympathetics as rest and digest, and the sympathetics as fight or flight. So here's a diagram overview of the nervous system. And as you can see, the sympathetic nerves actually do not come out of the spinal nerves in the cervical spine. They come out of the thorax. And so this is a thoracic lumbar distribution. And you can see the various things the sympathetic nerves do. They prepare us for fight or flight. And so they're going to dilate the pupils, inhibit salivation, increase our heart rate, relax our airways. They're going to decrease motility in the gut. And you can see, you know, all the way down here, thank God it promotes ejaculation and vaginal contraction. Okay, but on the sympathetic side of things, this is called basically craniosacral distribution, because sympathetic nerves come primarily out of the cranium directly in the cranial nerves, and then they come out of the sacrum. And thank God for parasympathetics working as well. Okay, so I appreciate them hopefully every day. So a simplistic overview of the immune system. This is a paper that actually does a nice job of kind of introducing concepts of how the immune system is regulated. And it's a little beyond the lecture for me to go into a lot of detail on it. But I do want to point out a couple of things that Hushman pointed out. It's very interesting. In the first 2 years of CRPS, the T cells are upregulated. And I actually have a friend whose mother was diagnosed with a lymphoma, and Glenn got a hold of me, you know, it was elevated T cells, and he actually did sympathetic blocks on his mother, and the T cell count went back down again. And so the neurologist was the oncologist was very interested, you know, what's going on, and basically it's blocking the sympathetics that are upregulating the immune system initially. And then eventually the immune system is downregulated, and this is when patients are more prone to develop cancer and things like this from the immune problem. Simplistic overview is that Hushman claims unnecessary surgery, alcohol, narcotics, benzodiazepines, all these make the immune system worse. Continuous distress due to legal entanglements to the trauma also cause RSD and affect the immune system. Inactivity and lack of exercise is a bad thing. I tell my patients they have to sweat every day. I don't care what they do. I want them to get to the point of sweating every day, so they're doing something that the sympathetics actually normally do. And then he was focused on nitrates or nitrites as cause for this as well. And he said use of ice on the extremity is going to increase the CRPS RSD, and that eventually will also impact the immune system. Okay, so the anatomy, I know you all love anatomy, so I'll make it real hard on you. This starts in the hypothalamus, and in particular, with the sympathetic nerves, there's a pathway that'll go directly into the teeth, or indirectly into the teeth. So remember, autonomic nervous system is balanced between sympathetics and parasympathetics. Many of these nerves eventually join together. Many times they stay separated. But here's the overview, and what I want to draw your attention to is basically that first order neurons are going to start in the hypothalamus, and they're going to skip all the way through the cervical spine, and they're going to come out the thoracic spine, okay? And from there, they are going to go up and down, T1 through T6 or T8. Sympathetic nerves go up and down. They can go up and form ganglia in the neck, or they can go down and form ganglia lower in the body. And eventually, these nerves will follow blood vessels. So sympathetic nerves are more or less hitchhikers. Once they exit the spine, they're then going to go to another nerve to distribute through the body, or they're eventually going to find their way to the internal and external carotid. And then from there follow all of the branches, ultimately back to the dental pulp. And so we have what we call first order, second order, and third order neurons. And so we can obviously try to block these at the second order or at the third order. We can't really block it in the brain. But if we could block a sympathetic ganglion, for example, that might help us. So here's first order. Hypothalamus comes down, lateral horn of the spine, out thoracic spine, roots into three different cervical ganglia. It's the superior cervical ganglia that then sends more sympathetics to the blood vessels. And so once those vessels, or once those sympathetics go to the carotid system, now they go everywhere arteries go, okay? And that in a nutshell is how sympathetic nerves regulate blood flow and how they can decrease blood flow in one area and increase it in another area, because there's this exquisite mechanism of changing this blood flow throughout the face. So eventually, these same tracts will eventually get to the teeth. So think about sympathetic innervation having to come through the thoracic spine. And this is why people may have trauma in the thorax and pain in the face. It's sympathetics. And it's all in the anatomy of how things flow. And so, again, it's first, second, third order neurons. And the third order neurons are the hitchhikers with other nerves and with other blood vessels. And eventually this will get to the dental pulp. And you can see the distribution of fibers in the pulp. And again, the sympathetics are abundant in periodontium and pulp to regulate blood flow. That's a lot of what they're doing. And so you're going to have arterioles and end capillaries, just like anywhere else in the body, all regulated by sympathetic nerves. There may be a sleep connection. The pineal gland is actually innervated directly by the sympathetics coming off the middle meningeal artery. And as you know, the pineal gland actually makes melatonin. And so people with CRPS have very poor regulation of sleep, and nobody's really explained it. But I have to think that somehow it may be regulated through the pineal gland, where the sympathetics just aren't allowing the melatonin production to be normal. And a thought on some of these patients might be to supplement, for example, with melatonin. So the cause of it, 90% of patients have a history of an initiating noxious event. And in the mouth, that can be something really minor, okay? It's unclear why they get it. Why do some people get it? Why do others not? And there's not a single mechanism to explain exactly what's happening. There are thoughts, and the list is here, thoughts about what may set the patient up for this. And so, stress may be one. We actually ran a database for a number of years and looked at risk factors for CRPS, and familial hypertension was a risk factor. That's one thing that really stood out in in things in medical history. Psychological factors, anger, depression, blaming others. This is a real problem in these patients because they drive their condition and they make it worse. And so until they can let go of that kind of thing, they oftentimes continue to upregulate what they're going to be suffering. And again, this happens a number of different ways.
I had twins. I gave birth to twins 7 years ago. And almost immediately after that, I started having various issues as far as pain in various places and to various locations on the right side of my body.
I just woke up in the middle of the night about a month ago, and the pain was just so bad, it felt like everything had torn out. And it's just gotten steadily worse since. Nothing is relieving it, not even strong pain medication. It's not really helping.
And this started out as a jaw problem?
Yes.
A long time ago.
Yeah.
Where do you feel your pain? What's the extent of where you feel it's not?
Almost the whole right, down the shoulder and down into my hand.
When you came in, you told me about this pain that you're getting in your body. And what I'd like you to do is just describe what that pain is like and where it goes.
Dropping from top of the head down to the feet.
Migraines, okay?
What did you do before that? I mean, what caused the migraines, did you think? Right.
When I first noticed sort of a popping feeling or clicking in my right upper jaw up here in 2007, late 2007, after I got my wisdom teeth out.
So, dental procedures, they're a part of the complex. So how do we diagnose this and how do we screen the patients? And you have to start out, there really is no specific diagnostic test. You have to go on the signs and symptoms from the IASP, but I'll show you some of the things that are done, and oftentimes this other testing is done to rule out other problems. For example, in the radiography CT arena, you're looking for other diseases, sinus disease, bona fide dental disease, and so forth. You want to rule those out with that type of testing. And then obviously with MRI, we're looking basically lower 20% or so of the brain, skull base, deep face, and TM joints. And again, that's to rule out other causes. So you'll fulfill the first line of making a CRPS diagnosis, and that is rule out other things that may be explaining this. So from the CT, we obviously get different imaging. Now, if you look at this patient, you're probably drawn initially to the left TMJ, okay? The CRPS is actually on the right side. And so as an adult, she's developing degeneration of the right condyle, losing cortication of the condyle. This is actively degenerating on the side of the CRPS. And disc displacement has been there for a long time. It's part of the problem, but the CRPS is probably playing into the necrotic process. Here's your cervical spine. You can see reverse lordotic curve, actually getting a little anterolisthesis of C3 on C4. That's where the vertebral body actually slips in front of the one below it. A little bit of that's going on C4 and C5. And there's almost a scoliotic appearance to the cervical spine, especially when you look at it from the anterior and posterior. But the absolute best way of diagnosing this condition is this way. You first get C0, which is skull base without cervical vertebrae. And then you add C1. And I want you to look at the transverse process of C1 on her right to her mastoid bone, and look at it on the left, okay? Look at transverse process to the styloid process on the right, look at it on the left. C1 is significantly rotated, and going right through the foramina in C1 right here is vertebral artery, totally enclosed by sympathetic nerves. And the vertebral artery, I mean, you got two in your neck. Those are two of the major blood supplies to the brain. And so we're looking very, very carefully at C1 and C2 malalignment as contributors to migraines and headaches and so forth, because anatomically the defect is there. And then here's her TMJ. This is the more chronic left side, and this is what a normal T2 and STIR would look like, relatively dark marrow signal. And here's the ear canal on the left. I point that out, so when you look at the ear canal on the right, look at the edema. Okay, so that's an edematous ear canal, and we just happen to pick it up on the STIR sequence on the MR. And she's got subarticular edema. It's not real bad, but there's some of it right there. That's subadjacent to where the degeneration is occurring. Bone density testing, that's another thing that's done on these patients, all indirect testing. Actually, bony atrophy can occur very quickly in the extremity. It's within like 2 to 3 weeks. You can see evidence of extremity osteopenia in patients with CRPS. Thermography is an old technique. I used to use it. There are much more sophisticated ways of doing this now, where thermography can actually measure the temperature of the skin. So these people are put into a temperature-controlled room, stripped down, and they have to equilibrate with the room temperature for so many minutes. And then these thermographic cameras can take photographs of their blood flow. And this is one way of tracking some of this. But again, in terms of being diagnostic, you can't say this is CRPS, you can say there's decreased blood flow. And there are ways of doing sweat testing, okay? Indicator starch powder is used for that. And then traditionally in medicine, you can use EMG and nerve conduction studies. The problem is they've got hyperesthesia to the needles, and so it's going to bother them somewhat. In the face, again, you want to take a careful history, and you want to be particularly aware of what I call a threshold event. A threshold event, in my observation, is that the event that causes the onset of the CRPS is not the first event in the region. Typically, they've had other events before that. And threshold event very oftentimes is third or more. And so let's say they've had sinus surgery, and then they had their wisdom teeth out, Shepherd procedure, and then they get TMJ surgery. The TMJ surgery may trigger the CRPS, okay? So if the surgeon's not aware of that and pre-blocking for CRPS, they're escalating the chance that the patient may have this. And a lot of times, the more innocent dental procedures, cleaning the teeth, the things we do every day, become the threshold event. But again, very oftentimes there have been prior car accidents, prior traumas, and so on and so forth. We do want to do a thorough exam, and again, it's kind of outside the scope of this lecture, but you want to do a thorough exam in the facial skeleton and in the bite, and look for distortions. So obviously this lady's got a whole lot more going on than CRPS and a TMJ problem. She's got a bite problem as well. And guess what? That's the world of these patients. They have these various things going on, and it's not unusual to see these types of distortions, especially in CRPS. And then there are laboratory studies, but they're primarily markers for inflammation. And so the laboratory studies are basically looking for inflammatory changes and ruling out other things. So there is no direct blood test for CRPS type 1. And the key thing in diagnosis is really nerve blocking. And so this is where you kind of have to know the anatomy of the environment, and you do nerve blocking and isolate sympathetic nerves where they're hitchhiking with other structures and try to get them blocked. Now, the best block is really stellate ganglion. I'll show you what that looks like here in a minute. But the nerve blocks are a key part of sorting out sensory pain in the neck, sensory pain in the face, and then combination of sensory and sympathetic pain, either facial or cervical. And so we rely on the nerve blocks a lot. And if you understand the anatomy, you can see right here, this is labeled greater auricular nerve. So the greater auricular nerve has gray rami, and all that means is that there are non-myelinated sympathetic nerves that track with the ventral rami of spinal nerves in the cervical spine. And so as they track with those nerves come together and form a cervical plexus, and then they branch out into end nerves. So the ventral nerves, the front ones in the neck, have great rami, and there are two that go up by the face. One is the greater auricular, and that's right here, and it crosses the angle of the mandible, actually a little further forward than what they show right here. It'll cross here, and then the lesser occipital is back here, and then there's a third one, transverse cervical. And if you look at the transverse cervical, it comes across the front of the neck, and it goes up underneath the mandible. And here's a pearl. In the mandible, usually in the molar, when you can't get them numb, it's because it's innervated by cervical sympathetics as well. And so to get a tooth numb to work on it, you would give the traditional block you do intraorally, but you have to go to the neck, or somebody does, and block the cervical region and block the cervical sympathetics. So we can isolate these nerves. I could do just greater auricular, I could do lesser occipital, or I could come down here a little lower on the sternocleidomastoid muscle, and as I do that, I'm hitting all three branches. And so it's kind of a nice nerve block. I'll show you what it's like and patient's response to that particular block. Here's something most people don't realize, and that is that when you look at the ear, the auriculotemporal nerve only innervates the upper anterior quadrant. The rest of the nerve is basically innervated by the cervical region, okay? And then it's cranial nerves that innervate the canal. So 3/4 of the ear is innervated by nerves coming out of the cervical spine. So if somebody comes in and says they have ear pain, you have to track it down. Is it the ear? Is it in the TMJ, or is it in the cervical spine? And a very efficient way of doing that is to do the nerve blocking and try to figure out where they are. So let's look at this. This is sorting out masticatory system pain. And the way this is done primarily is just simply blocking the TMJ. Now, the auriculotemporal nerve, which is what I'll show here being blocked, actually picks up sympathetic nerves from the middle meningeal artery. This nerve's pretty interesting. It actually splits and goes both sides of the middle meningeal artery right at the foramen spinosum. And so sympathetic fibers are getting to the auriculotemporal nerve before it even goes to the TMJ. Okay? So a lot of times you'll get stimulation of sympathetics right there in the TMJ and the retrodiscal attachment tissues and with the disc displacement because of the anatomy. So sorting out trigeminal pain, this is the key block. Now you can block any of the divisions, obviously, or any of the branches, obviously, to sort through pain, but a key block that is both facial sensory and facial sympathetic is actually the main block to the TMJ at the auriculotemporal nerve. And then this is sorting out dorsal cervical pain. So this would be pain kind of in the back part of the skull. And this would be greater occipital nerve and least or third occipital nerve. And these are basically C2 for the most part. Spinal nerves come out of the spine and they split front and back. These would be the back or dorsal ones. And these do not contain the sympathetics that the others do. The primary sympathetics are going to follow the ventral cervical roots, and this is where you go down into the neck and you do the cervical block at the level of the greater occipital nerve or cervical plexus. And this block is basically done like this. You find the sternocleidomastoid muscle across from the angle of the mandible, and you want to drop down a little bit from there if you're just getting greater auricular nerve. And if you're going to get more of the nerve bundle, you would go even a little bit lower, and then you'll get your transverse cervical and so on and so forth. This block takes away tooth pain. This block stops the pain that's referred to the TMJ. This block stops the dystonia. Okay? It does all of those various things. There is a deeper one. In the cervical spine, there are 3 sympathetic ganglia, but the one that's usually blocked is the lowest one, or also known as the stellate ganglion. And I refer this out. I don't do this. The medical legal environment at this point is that the skill set is primarily with anesthesiologists, and pain specialists, but they're going to go basically transverse process C6 to C7. And that's right where the ganglion is. And what they do, when they interrupt it there, they're blocking all of the sympathetics that are now coming up into the face. The problem is they're also blocking the 3 sympathetic nerves that end up going to the heart, so the heart rate can slow down. And so not always an easy block to get. That's why I prefer more of this block right here that I'm going to show you and demonstrate on this patient.
The block I'm thinking of is actually a neck block. And what it does is it gets cervical pain fibers that refer into the face. And it also includes some of the sympathetic nerves that are involved with CRPS. And so I'd be very interested to know what that kind of block would do for your pain. And the way this would work is I'll give you the block, and within a minute or so, you just tell me if you feel any better, if you feel better where that improvement is going on. And I'm using a tiny needle here, and we'll see if that doesn't work a little bit better for you, okay? Mm-hmm. All right, you doing okay with that? Mm-hmm. I'm getting a little bit of a sting now. How is that? Is that too unpleasant, or are you doing okay with it?
I'm okay.
Okay, that's great. I'm going to put a little bit of this in right here. I'm going to switch this, and we're going to come in the other way. So let me ask you this. If you try to open your jaw widely, remember how that felt earlier today?
Mm-hmm.
What happens when you do that now? Is there any difference, or is it the same as it was?
That feels much, I don't feel, it doesn't feel as painful.
And what you're talking about is this morning when I examined you, I took your head and I just put light pressure on it, about like that.
Right, and that's not bothering me like it was this morning.
But this morning it escalated pain all the way up through your face, didn't it?
Yes.
Yeah. If you tap your teeth, are they sore?
No.
Or do they feel any different?
They don't, I was feeling pain, like a shooting pain in my bottom 2 teeth when I would tap them together, and
Can you make it shoot? Can you do anything to make that hurt?
that doesn't seem to hurt like it was earlier.
Can you remember this morning I manipulated your jaw?
Yes, and I've been spending the whole day, and I have a lot of trouble with the shifting my jaw, the left to right motion is extremely difficult.
What about now?
That was much easier, and I didn't feel the same. I couldn't do to the right at all, hardly.
And if I take you, remember this morning, and I did this kind of gentle manipulation, and your jaw went back, and you touch your teeth lightly. How is that now? Let it open up again. And I'm putting pretty good pressure on your jaw joints, which I know are damaged, but how is that compared to what it was like before the block?
It feels completely different because I can sense that you're manipulating my jaw, but it's not causing the same type of painful reaction. It's just not as, it's not unbearable to have my teeth touch each other or to utilize those muscles.
Before when I did that, I was seating the joint, and that was painful.
Yes.
And still painful now, or is it better?
It's better.
So that's a neck block, but the response is in the face, okay? So I'm going to work my way to respect the time and just say to you that there is a migraine link, perhaps, and again, foramen spinosum is right here, anteromedial to the medial pole of the condyle. That's where the middle meningeal artery is going into the brain. Now, it's controversial as to whether that's what dilates in the migraine. So the medical literature is not clear on it, but there's tremendous sympathetic innervation right in that area, and that's right where the the auriculotemporal nerve is going to wrap around the artery before it goes to the temporomandibular joint. And that would be right here, just after it comes out of the foramen ovale. Okay, so treatment, very briefly. There is pharmacological management, okay? And anti-inflammatory medications, there's a whole host of them. And again, if you get the lecture from Bioresearch, you'll have all this information here as to dosing for anti-inflammatories. But what you want to do with an anti-inflammatory is make sure it gets in the brain with centrally maintained pain. And there are studies that will actually show the ability of anti-inflammatory medications to cross the blood-brain barrier. Peroxicam is a great drug in that regard. And you can see the list here. Actually, in the over-the-counters, ibuprofen has a very good tendency to cross the blood-brain barrier. So it would actually be a very good choice for CRPS patients. And you can always use steroids. And so steroids are one pathway. They will help with edema. And then when it comes to muscle relaxers, I'm going to draw your attention to clonazepam. Clonazepam is the least addictive of the benzodiazepines, and typically 0.5 milligram dosing, sometimes 0.25 QID. I layer the muscle relaxation from Klonopin in there because it's also an anxiolytic. So when you get a high-stress individual, their stress will drive the CRPS, and this is one way of bringing it down. And then, as you know, the literature is full of things about bruxism, and there's a lot really not proven to be effective, and the tricyclics kind of fall into that class. Trazodone, which is what I use, the decylyl trazodone, 25 to 50 milligrams at night, that's not really been studied, but seemingly, from a clinical standpoint, it seems to do pretty well. And then in terms of neuropathic facial pain, gabapentin and pregabalin, Neurontin and Lyrica are probably our best drugs that we can use right now. Naloxone is actually being used experimentally as an antagonist, but actually people with CRPS have been found to actually respond to it. So, true TMJ disease is commonly related to TMJ pathology, and RSD is a complication of it. So you are going to see it, and when you have a sensory problem and a CRPS problem, you get into what's called a wind-up. The sensory pain winds up the CRPS pain winds up the sensory pain, and you get into this vicious cycle. There are protocols that we use in the CRPS RSD surgical patient. They do get a stellate ganglion block preoperatively to preempt the problem. Their TMJs are blocked during the surgery, and then they're reblocked at the greater auricular nerve, the cervical plexus at the end. And they're given ketamine. Ketamine is an anesthetic agent that actually has been found to decrease the response to CRPS. And you get about a 10 to 14 day carryover of pain reduction after giving them 1 milligram per kilogram of ketamine during the anesthetic. Obviously, we want to use heat and we want to rest the system afterwards. Okay? So, real quickly, CRPS does cause a nebulous occlusion. It's going to cause a dystonia in the mandible. And I want to get to a couple of patient examples of what this is. This patient suffered from metal deficiency disorder. And so you can see she's had a few implants and a few metal things placed. But this was a patient who just simply kept getting worse. She had an osteotomy, both arches, dental implants. And she had a nebulous occlusion because the mandible was in such dystonia, we couldn't get her bite stable. And she had to, literally to be blocked on, she had to have the greater auricular nerve blocks in order to do the dental work, and here's her metal deficiency in more detail. So at any rate, these patients, orthodontic procedures are painful to them. They can create a lot of problems. This guy right here, if you look at him, big guy, he had 300 plus dental visits dating back to 2001. Same dentist, okay? and he couldn't get his bite right, okay, and that's the nebulous occlusion. Thank goodness his TMJs didn't want that bad, so I could punt back. This guy was restored by one of the biggest names in restorative dentistry, and he was on a mission for a period of 30 years. He toured the entire country collecting specialist names, and he beat every one of them, okay? And he had cribs. He was adjusting his own bite, okay? And this is how he walked into my office. Again, thank goodness, no TMJ problems. Patient treated with a Mago splint, followed by a very minor orthodontic procedure. She developed facial cribs, okay? And was very, very unhappy with the treating dentist. And she had dystonic occlusion, again, making it very, very difficult to treat her bite. This is the end stage. This was a botched surgery. They did an eminectomy. And in the hypoxic environment of cribs, there can be proliferation of bone. This is her TMJ right here. So totally obliterated by overgrown bone. And there are special procedures we do, stealth-assisted surgery, where we're using a computer and a CT at the time of cleanup to try to remake or carve a TMJ out of this solid bone structure. And then fat is placed. Fat's a great modulator of cribs because these gray rami from cribs nerves are non-myelinated. So they have no myelin sheath, and fat can actually act very much like myelin and reduce their pain tremendously. So the point is you recreate a joint like this, you put fat in to modulate the nerve pain down. There's the removed bone. And then this is the post-operative scan showing the recreated temporomandibular joint. So I'm going to go right to the concluding slides. Okay, take-home message. Most commonly, the pain is going to be teeth or TMJ, and the pain is burning as pathognomonic. In the vasomotor end of things, you do see color changes and temperature changes. Most often the temperature changes are easiest to pick up in the fingers, and they could even have a Raynaud's type phenomenon in the hand that they didn't have prior to that. And then edema and sweating asymmetry. The edema is most notable in the pinna of the ear, and again you can see it around the orbit. They may have gingival edema, marginal gingivitis, and again that's just an extension of the whole process. The real red flag is pulpal edema or pulpitis, and we certainly don't want to get these patients into root canal therapy. And then the motor difficulties are primarily mandible, but again it can be facial musculature. The jaw just doesn't move right, or the jaw may be held in a protruded posture, or the jaw may be held in a lateral posture, one side or the other, and then the atrophy is there and eventually gets in the bone. So concluding thoughts, these are some things I put together that I've wondered about, and I'll just share them with you. In the hyperesthesia or allodynia, are we making the correct diagnosis using the term TMD? Because what we find in these patients is pain patterning that's called TMD, I can take away with a TMJ block. I can take it away with occlusal therapy or occlusal blocks, and I can take it away with cervical blocks. So is TMD maybe not just a form of CRPS type 1 in the face? Okay? Is positive cold stimulation of the teeth after trauma pathognomonic? Because these people can't take cold exposure to their teeth, okay? And I know we use that for a diagnostic tool for looking for equilibration and things like that, but is there a bigger monster lurking underneath the teeth that could be this CRPS condition? Vasomotor, are we simply overlooking color changes and asymmetrical temperature? Probably so. Most of us don't examine for that. And then, are we making a correct diagnosis of pulpitis and trauma? Trauma to the thorax, painful pulp? No. That's got to be CRPS unless the tooth was directly traumatized. And then the motor dysfunction. When we call something an occlusal muscle disorder, and and somebody has a prematurity on a molar, and that molar is painful, and every time they touch that molar, they trigger generalized muscle spasm. Is it really through the trigeminal nerve, or is it maybe through the sympathetics? And I would say the more generalized the muscle dystonia, the more likely it's coming through the sympathetics. And then connection to other areas. When you look at sympathetics, there may very well be a migraine connection. The anatomy is right there. And the auriculotemporal nerve does wrap the middle meningeal artery. And then the other thing is melatonin production may be totally altered because sympathetic discharge to the pineal gland is going to be changed. And that may be the explanation for the sleep disorder. And so anyway, I leave you with these thoughts that, you know, this is a problem oftentimes overlooked. Don't buy that it doesn't exist in the face. I see a lot of these patients every year, and I can almost guarantee everybody in the room's got one, probably more, okay? So hopefully today's lecture gave you a little bit of insight into something a little bit different that you can put into your armamentarium for diagnosis. And parting thoughts, just be careful. Thank you. Class dismissed.
Yes, there's a reason. It's like what's